So the goal of management is to reduce or eliminate the occurrence of severe neonatal hyperbilirubinemia and bilirubin encephalopathy. We should decrease unintended harm, however, as increased anxiety may happen if we worry the parents with the levels. Decreased breastfeeding because of possible separation or even phototherapy may inhibit, make the mother more anxious and inhibit milk output. We may unnecessarily treat or make the samples frequently, which results in pain for the baby, and of course, excessive cost and wastage of resources if you don't follow a proper guideline or over-treat. As I said earlier, the AAP came out with a clinical practice guideline, management of hyperbilirubinemia in newborn infants 35 or more weeks of gestation. This came out in 2004 and an update in 2009. In terms of maternal screening, that's mainly to find out whether the baby will be at risk of jaundice. So we have the ABO and RH blood types. The serum screen for unusual isoimmune antibodies should also be done on all pregnant women. If the mother is not screened or is RH negative, blood group and Coombs test should be done on the infant's blood. If the mother is O positive, there is an option to test the baby's type and the direct antibody test, especially if the baby's blood type is A or B or AB. As the ABO incompatibility is a less severe form of the disease and the RH incompatibility, this testing can be done if required based on the clinical surveillance. Newborn should be routinely monitored for jaundice, and all nurseries should have established protocols for jaundice management. The protocol should include the condition under which the nurse can obtain a total serum bilirubin or a transcutaneous serum bilirubin level. So a guideline in place where the nurse is empowered and proper education sessions so they're aware of what they are doing, they can clarify parents' questions and inform the doctors where there is a concern should all be included in your training package. Provide information for parents at discharge explaining the significance of jaundice, the need to monitor. It's also important to ensure that the feeding is established adequately at this stage. A bilirubin measurement should be done on any baby less than 24 hours old who is jaundiced or is high risk due to the blood group related factors. The transcutaneous bilirubin should be measured in all babies at 24 hours and then pre-discharge depending on the timing of discharge. If it's a cesarean delivery and the baby is going to stay for 3 days, we can check it every 12 to 24 hours depending on the previous measurements. The need and timing of another bilirubin test depends on the risk zone into which the bilirubin falls, the age of the infant, and the risk factors. All the bilirubin levels should be interpreted according to the baby's age in hours.